Okay, it's a few days after the IAOMT meeting, and in my lecture we had AV problems, so they asked me to do this at home. So here I am, and I would like all to know that this is something that GPs and specialists both should pay attention to. There's some new research in here that I think is very practical and very salient for anyone that deals with unexplained problems during dental treatment and diagnostics. So let's start. It should take me about 90 minutes, and I need to make the statement that I do not receive any remuneration for any of the products or technologies discussed within the lecture. I'm basically independent. There's nothing there for me to sell. Beyond, I will mention that I do have a teaching center called the Center for Neural Occlusion, the CNO. You can find that at cnodoctors.com, but products and technologies and all that, I have nothing to do with sales, etc. So a disclaimer. The motto for the CNO is that measured matters. And by the way, in the lecture, anytime a pearl drops, like you see in the upper left of the screen, that means it's worthy of taking a screenshot, in my opinion. So if you see the pearl, take a screenshot if you're interested. So I'm a GP in Rogers, Arkansas, which is basically the home country for Walmart, J.B. Hunt, Tyson. All these different corporate headquarters are based here. So it's not your typical Arkansas. This is a very wealthy, very affluent area of the country. And I run a solo insurance independent and corporate independent private practice. And one of the reasons I formed the CNO, the teaching center, was to show other people how to do the same thing. Because I'm kind of old school, I guess. I'm about 31 years into practice, and I don't like being told what to do. So pay attention if you're like me. Anyhow, there's Northwest Arkansas. Measured matters is the motto of the CNO. A quick collage of our daily activities in my office. On the regular, I shoot MRI. We draw PRF. We use solid, liquid, concentrated PRF, all sorts of microscopes. A lot of CEREC, a lot of orofacial pain diagnostics, a lot of CT work, a lot of laser dentistry. I'd consider myself a holistic dentist in a very big way. And quick look at my personal life. I love to fish. I have a beautiful wife and children. They're grown now, thank goodness. I have some beautiful Shih Tzus. And let's move on. So, in my opinion, holistic means common sense. So, you get into dental school, they tell you that mercury is safe, but in college, when you're taking all that chemistry, you're looking at the periodic table. I mean, I'm preaching to the choir with this crowd here, but basically, I consider this stuff common sense based on science, and I want to help people. Don't want to hurt them. So, not only am I a practitioner, though, I'm also a part-time author and researcher. I've self-initiated numerous studies in my career, in my practice, and published multiple times. We'll talk about that for a quick minute. And the primary topics would be digital occlusal metrics, 3D imaging, including MRI and CT. TMJ imaging is very salient for all practitioners, whether you know it or not. The sympathetics, the autonomics in dental practice, that's huge important, and a lot of this lecture will be centered around that. And then hypersensitive teeth, or dental allodynias, we'll talk about that in a few minutes. There are some of the publications that I've been involved in. The one on the left over here, the FDH study, and the one on the right, the GAN study, are primarily salient to this lecture. The FDH study, we were able to quantify how occlusion can cause hypersensitivity in teeth to cold. In the GAN study, conversely, we found that blocking a nerve in the neck can stop teeth from being cold sensitive temporarily. This is more permanent when you alter the occlusion accordingly. This is something diagnostic. We call this FDH, frictional dental hypersensitivity. We call this SDH, sympathetic dental hypersensitivity. By the end of the lecture, you guys will understand this. So the papers primarily deal with occlusion, joint vibration analysis, which is a screening tool to kind of vet the joints. I do that on every patient that walks in my office. FDH, which is the occlusal cold sensitivity concept. Frictional dental hypersensitivity is the name of that. Hypersensitivity in general, cold, when you can't figure out what's going on, why is this tooth still sensitive? Why is this whole quadrant a problem? Or, what's going on here? Is this CDH? Is it DH? Is it something else? Occlusally driven or diagnostically driven via digital metrics, occlusal adjustments. That's addressed in these papers. A lot of depression studies, sympathetics and cold, etc., etc. I'm also a co-author in what I call the Tscan Bible. I don't know if any of you use a Tscan, but you should. There's a quick look at a way to digitally study force per unit time between the dental arches. It's amazing. I use it constantly in general practice, not just for orofacial pain stuff. It's a must for FDH. If you're trying to track and predictably diagnose and treat hypersensitivity due to the occlusion, you have to have one of these. You can't get by with ribbon. We'll talk about that later. Anyhow, so the third edition of this textbook is coming out actually probably in September. We just did the proofing. I did my own proofing for my chapter back about 2 days ago. So that should be live anytime, and I highly recommend you guys look into this. If you have any interest at all in occlusion, and as dentists, I think we should be experts at teeth, gums, and bites. And, I mean, digital trumps analog any day of the week when it comes to this realm. So that's coming out, and in my chapter, we delve heavily on sympathetics, TMJ imaging with MRI and CT, hypersensitive teeth, occlusal adjustments, digital occlusion in general, the FDH concept relative to force and time and how that affects occlusion. In other words, why are people sensitive from the bite? Sympathetic dental hypersensitivity is mentioned, like the second paper that I showed a few moments ago. Electromyography, various iterations, we talk about that in the chapter, or I talk about that. Lasers, primarily erbium and neodymium. I'm a big Lightwalker user, have been for many years. And ozone. So this audience will be familiar with a lot of these things, and many will not. The chapter was 52,000 words long, by the way, and there's no money made in these kind of endeavors, believe me. You got to be pretty passionate to be able to spend the amount of time it takes to put one of these together. It took me about a year to write the first edition. And then subsequent editions, you just kind of update, check, and vet, and, you know, make it more modern. So let's get to the FDH paper real quickly. So basically, once again, there's the T-scan, and there's a patient biting on it. These electrodes are basically measuring anterior temporalis and masseter muscular output in microvolts. And we can slave the T-scan tech to the electromyography electrodes. So I can see what hits when and what the muscles are doing every 3,000 of a second increment. In other words, I take a bite, it takes a couple seconds, and I have hundreds of slides I can look at. I can watch what a deflection and the excursive movements, for example, did to the temporalis on the right or the left or both, etc. So back when we published this study back in 2017, I was the first to publish on this topic, and I called this frictional dental, not dentinal, hypersensitivity. And basically the N was 100 patients, and the pre-op swish to ice water, and we'll talk about that in a moment. I basically had people swish ice water. How sensitive are you? 0 to 10. 10 is the most unbearable pain ever. 0 is nothing. The average of over the 100 patients was a 5.35. After the occlusal adjustments, following the data from the T-scan and the EMG linked, it was 1.73, and it was lasting. Generally, this is lasting, and it's pretty much permanent unless something changes. Okay? So, and the P was less than, probability value less than 0.0001. For those who don't know, a probability value that's less than 0.05 or smaller is statistically significant. This was very significant, very relevant. So here's the recent study that we just published, or I just published, with John Radke and Tom Coleman this past summer. This has to do with the sympathetics, the C-spine, sympathetic dental hypersensitivity. Basically, if you look at the photo with the injection, just kind of posterior to the SCM right there, we're injecting local anesthetic and we're blocking a nerve called the great auricular nerve, hence the GAN study. And basically we showed, and I've been doing this for years, but I had to put this in the literature because it doesn't exist yet. We showed that through an N of 91 patients, the pre-op swish to the ice water was 6.41. The post-op was 3.92. The p-value was even smaller than the FDH study, 0.00001, an extra zero. Very, very statistically significant. So context I've already kind of mentioned, swish ice water for 5 seconds. Every patient that enters my practice, we do that. Especially on the new exams, the periodic exams. if they're coming in for some weird non-specific pain, or let's say they had a crown and 2 fillings done last week, and they're sensitive to cold. We'd like to quantify that. We get a baseline. It's a little bit subjective, of course, but have them swish ice water, 5 seconds. Hey, where's it sensitive? Tell us. Record it. Figure out how to treat it once you diagnose it, and we'll talk about that in this lecture. And then have them swish again at the end. And typically, if you nail the right diagnosis, this will go down dramatically, statistically. All right, so 0 to 10 is the scale. And here's a quick video on CDH. We're all familiar with CDH and DH. Cervical dentinal hypersensitivity and dentinal hypersensitivity relating to open dentinal tubules.
6.5.
6-ish? And it's isolated one area.
Yeah, it's like right here. It's okay. He knows me now.
Okay, slap.
No, you're fine.
Not hurting, right? I'm going to do the whole area. So there's little open tunnels, little tubules, microscopic, and laser energy clogs them all up. Right now I'm going to hit it with a different kind of laser energy. Not hurting, is it? Change. Yep.
It's a huge change. It feels like normal.
What do you got? You have 6.5. What do you got now?
Like nothing.
1, 0, something?
Yeah. I kind of can't believe it. that took like 2 minutes and there were no needles. Yeah.
No needles, no Sensodyne, none of that. And this should be lasting, by the way.
Yeah. That's awesome.
We didn't put any medicine on her, did we?
No.
What do you think?
I think it was great.
Okay, that was CDH and DH. We're using lasers and ozone, and we'll talk about that later in the lecture as well. Here's a quick video on FDH, frictional dental hypersensitivity, dealing with a bite and how the bite can cause teeth to be cold sensitive. Torsional flexure, A beta, edema, we'll get to that later. Quick video. So tell us what just happened.
Yeah, well, I had sensitivity to cold water, and then you, doctor, adjusted my whatever, I don't know.
Your bite with a computer.
My bite with a computer.
Yep.
And it's completely gone. I don't have sensitivity
Yeah,
anymore.
give us a swish.
Yeah.
So they put a crown in years ago. They never got the bite right. Yeah. So we adjusted your bite using the computer data
Yeah.
to guide our way.
Completely different. Night and day.
When you swished an hour ago before you came in here, what was that?
I could feel it. Well, it was a 5.
5
It wasn't
out of 10?
like excruciating.
And now?
But now it's nothing.
Is that pretty cool?
Yeah, it's really cool.
So basically, this patient had a zirconia crown put on one of her lower molars, and for 5 years it was messing with her, and nobody could figure it out. And she was a new patient, and as I mentioned earlier, we always use JVA, joint vibration analysis, on patients to vet the joints. And I saw her, and I found over the years this is an excellent way to, like, win the patient's trust, do something that others cannot do, and it allows you to become, example, insurance independent. Example, I don't need to go to corporate. I mean, this minor thing is a big deal, because when you do something other people can't, that sets you apart from the rest. This is kind of the impetus of this lecture. If you can understand hypersensitive teeth, even though it seems like a trite thing, it's a big deal to patients. And then there's SDH, which deals with the autonomic sympathetics, and we're dealing with the greater auricular nerve block, and we will talk about that later. Okay, so I like to think about the medical classification system called nosology. So in other words, like, what's going on? This is how you classify disease processes. And you have a phenotype, and you'll have an endotype. So a phenotype would be a subclassification, so would an endotype. A phenotype, an example, I've got asthma. Well, there's many causes for asthma. What's the cause? Why? Why are they wheezing? Why are they having hypoxia? Another example would be headaches. Okay, that's a general term. What kind of headaches are we talking about? Tension headaches, migraines. Causes are different. So it's very relevant, to figure out, like, what this stuff means. So what I'm getting at here is an endotype is actually looking at causation. So you're kind of subsetting and subtyping a condition, and you're looking for the distinct mechanism of causation. In other words, what caused the headache? What caused the sensitivity? what caused the asthma. All right, so we're going to endotype dental hypersensitivity in this lecture and look to the root cause, pun intended for this group. Haha, not very funny, I know. Anyhow, so as we all know, as dentists and specialists, there's various reasons people have cold hypersensitivity. And many of these are listed: open margins, decay, perio, cracked root, cracked crown, failing something or other, a failing filling. These things leak. It's basically a process of exclusion. We have to exclude other possibilities when we're looking for the root cause of what could be causing this here. So let's talk about diagnosing and understanding hypersensitivity. There's 4 endotypes. The first one is cervical dentinal. That's probably the most frequently encountered, rather. CDH, dentinal. Notice the AL, as in dentin. And then we have dentinal hypersensitivity. Again, dentinal. Then we have FDH, frictional dental. Notice the distinction. We're not dealing with dentin directly. And there's SDH, sympathetic dental. Again, not dealing with dentin. That's a pearl. So a patient like this, not a great example, but why would this person be cold sensitive? We don't have all the views, etc. We don't have recession, though, do we? We don't have caries. This is pretty much a virgin mouth, and the guy was cold sensitive. Why would that be? Now, why would this guy be cold sensitive to cold? An ice water swish. Why would this be wigging him out? That's a quick side story on this one. This guy came to me from basically Hollywood. I can't say names, of course, but there's a bunch of guys out there doing a lot of cosmetic dentistry. This guy had kind of a full mouth set of veneers and crowns done, spruced it up in his middle age, and chronic pain ensued. But one of his symptoms was extreme cold sensitivity that would come and go. And when we switched him the day we saw him, he was switching a 4 out of 10. Why would that be cold sensitive? Oh, and by the way, the endodontic work was them chasing a problem they could never figure out. We figured out the problem, and it was relating to the autonomics. All right, so let's define a dental allodynia real quick. A dental allodynia, basically when I say a dental allodynia, I'm expressing that we're dealing with a pain that's disproportionate to the inciting event. All of us have done something benign and minor and routine, and the patients come back repeatedly and with a pain that's way disproportionate to what we did. We took a tooth out. 4 months later, they've been back 3 or 4 times. They're complaining. The pain won't go away, something like that. Or we extracted a tooth on one side, but the other side is causing them pain all of a sudden. Another example would be cold sensitivity. Example, the preceding slide where we were looking at all those endo-treated teeth. He had 2 vital teeth there. Why would he be swishing a whole mouth 4 out of 10? Well, there's got to be a reason, right? Basically these patients are the ones that you want out of your practice. You need to send to the specialist. Technically or typically, we're not equipped. A lot of times we run into something we just can't handle. And this is a great example, the endo case. Why would he swish a 4 out of 10? That patient's nuts. Get him out of my practice, right? I mean, what are you going to do with this guy when he shows up 3 times? Let's say he wasn't coming to you for a facial pain like this one was. Let's say it was just, hey man, you did a bunch of root canals on me. And let's say they were valid. These weren't. And why are my teeth still cold sensitive? It's driving me crazy. I can't drink a cold beer. Can't drink a milkshake. Okay, so an allodynia is kind of an important thing to understand. So hypersensitive teeth. Confounding cases of hypersensitive teeth are examples of a dental allodynia. When you cannot figure out, you've gone through your process of exclusion, and you've treated them for a CDH and for DH, and you just don't know what the heck's going on here, I want you to learn today about FDH and SDH. It's that simple. So how I got exposed to this kind of stuff, many years ago, I started working in the orofacial pain realm and started kind of hobnobbing with some pretty brilliant people. And I don't want to get too deep into the story, but basically you'll understand the next few minutes. I started a YouTube channel, started publishing all these things. People come from all over the planet to see me. And basically they're hoping that I can help them through their bite with their chronic pain. And I have to make a statement that the NIH claims, if those that know this and those that don't, you need to know that the NIH statement on irreversible occlusal adjustment is such that it's never indicated. And I agree with them if you're not vetting the TMJs. If you're vetting the TMJs, I disagree with them. The joints are 2/3 of the human bite, and we're going to get into that in a few minutes. But I want to show you guys a quick video to give you an example of the kind of craziness I've seen over the years. So tell me, where are you from?
Ireland, Chicago, Pittsburgh,
Colorado,
Florida,
Missouri,
Canada, Germany, Colorado,
Los Angeles,
Calgary, Alberta, upstate New York,
the Bay Area,
Texas,
Memphis, Minnesota,
Florida,
Tennessee,
Saudi Arabia,
North Carolina,
Illinois,
Nevada,
New Jersey,
Turkey,
from Spain,
Missouri,
from New Orleans, Canada,
Indonesia,
Indonesia.
Australia.
I wanted a dentist who looked beyond just the teeth.
What is it?
Like a 7.
Okay. It doesn't linger, does it?
Just a little slightly on the back,
Back right or left?
right?
Love that ice water swish. Okay, so it's been, what, 24 hours?
Yes.
Almost. How do you feel?
I feel better. My bite is definitely different, but it's a good different. When I close my lips together, my teeth aren't clenching down on each other, so it's a little more relaxed.
Yeah?
No headaches this morning.
Do you typically have headaches in the
All the
morning?
time.
All the time. So this is exceptional. None?
Nothing at all. Wow. Nothing.
So what do you think?
It worked. That's awesome.
How cool is that?
Yeah, that's cool. Wow.
So you glad you had it done?
Yes.
This collage was put together 7 or 8 years ago, to be honest with you. It's old. And that map, that was to date 7 or 8 years ago. I literally have seen people from all over the planet for confounding dental allodynias, basically. You know, cold sensitivity, chronic headaches, tension in their muscles. They can't figure out what's going on. They've been to, on average, about 20 doctors. The record, I was the 63rd doctor they'd seen. So I've seen some crazy stuff, okay? They flew over a lot of docs to get to me. And I don't have all the answers, but I have more than most. And we're going to touch on a lot of those concepts here in this lecture. So basically, they were coming to me in the hopes that I could use my digital occlusal data to help them find resolution, or at least figure out what's wrong with them. And the neural occlusion screening protocol, that's something I created about 10 years ago. It's digitally generated, reproducible, and archivable using objective diagnostics. All right, so I'm putting numbers to sympathetic pain. I'm trying to figure out why are they having problems. And one of those allodynias happens to be hypersensitive teeth, oftentimes. That's kind of what pulled me into this world. So I'm using TMJ MRI and CT. I'm ordering, reading, and interpreting myself alongside a radiologist. But I honestly, most of the time, I find things the radiologist doesn't find. You know, I used to hang out with a guy named Mark Piper, Dr. Piper. We'll talk about that in a minute, a TMJ surgeon. And he taught me how to do these, the imaging. Digital mastication analysis, I put numbers to chewing. I mean, you can get a baseline and then you can do something, you know, treat them in a certain way, and then recheck and see if they're chewing more efficiently. That can be digitized. Electromyography, many iterations of EMG that we use to see what the muscle function is doing. HRV, to look at sympathetic tone. It gives me an idea. That's the least accurate and most variable part of the system, but, you know, we use it oftentimes. Velocity tracings, kinesiology of the mandible. How quick and how efficient is the mandible moving? I can have a tracing. I can watch. I can have them open and close, say 20 times, and look digitally, have a record. It's always there in the computer. You know, digital jaw tracking. How far in protrusive movement, excursive movement, etc. All these things. I can track these things, have a record. Again, baselines are important. Science, you need numbers, right? You need objective. Tscan linked EMG. The Tscan is that digital bite technology. Linked to electromyography, I mentioned earlier, we can check force per unit time, slave to muscle activity. So I actually have a record of the bite. And I use the Tscan standalone all the time in my general practice. Understand that 95% plus of what I do is GP stuff. Holistic GP stuff, high-tech GP stuff. It is not orofacial pain. But the orofacial pain world and my contributions there and my understanding of what's going on there, and that's a pretty tough world to live in, have made me a better dentist because I have a better understanding of bites, resultant of the years I was playing around with these toys. And they're not toys, they're amazing tools. And back in the day, about 2007 or 2008, when I first started using the T-Scan, I'm the one that discovered, all of a sudden, I'm adjusting a bite in the air and the water from the handpiece. As I'm adjusting occlusion, they're acutely sensitive initially. And then as I start adjusting based on the computerized data, in other words, I'm not following ink ribbon. And we'll understand here in a few minutes when we get to this other part of the lecture. But I'm noticing that As I proceed to adjust their occlusion based on the metrics and reading the data that the T-Scan can provide, they're losing their cold sensitivity. It's going away progressively. That's what gave me the idea around 2008 to have them all swish with ice water. Anyhow, sympathetic neck blocks, we'll get there towards the end of the lecture. That's also part of the neuro-occlusion screening. We call it NOS. So, this is a quick example of a T-scan linked to an EMG, what it looks like on the computer digitally. So basically, I'm looking at force on the Y per unit time on the X. So this data, here's a three-dimensional representation of it, and there's a two-dimensional representation of it. And simultaneously up here, I have a qualitative view of what the temporalis right and left are doing, and the master right and left, the closing muscles of mastication. Down here I have a quantitative view. And I can actually track on 2D a relative force percentage, like what's hitting when. This little center of force icon, that little kite there, is the average of all things touching in that moment. The bottom line is, when you're making an excursive movement, okay, so here's a quick pearl. Excursive movements are unbelievably important. It's not the MIP, it's not the CR, it's not the down and forwards, okay? It's the habitual closure if they have relatively stable and adapted joints, and if they're making an excursive movement, and they're having to climb over all these posterior teeth to make it to the anterior for the anterior guidance. We all understand that concept, canine hitting canine, separating posteriors. If it's very sloppy and it takes a long time to get off those back teeth, that can cause problems. Bottom line. And this lecture, we will not have time to go deeply into this world. You're welcome to come to the CNO if you ever want to learn this stuff, hands-on. But my point is, that's a quick look at the T-Scan EMG. So the YouTube channel, I started that around 2010, and I started posting videos about what I was seeing with T-Scan. And then all of a sudden, about a year or two later, I'm starting to get phone calls from all over the planet. Literally, that's kind of how the genesis of everything happened. And at this point in time, snapshot was about a month ago. I mean, for a dental channel to have almost 14,000 subscribers, 415 videos, I mean, I don't even populate it much anymore. I mean, back in the day, I used to do this on a weekly basis, but nowadays, I mean, look at those views. So why so many people? Why this big interest? Because there's a lot of people that have a problem that most dentists can't help them with. And a lot of dentists over the years have come to the CNO. That's why I formed the CNO, because there was a need. And I don't do it that much. We have an occasional course, 1 or 2 a year. It's very small, and it's word of mouth, and, you know, it's my way of giving back. Anyhow, quick look at a TMJ MRI. That's one of the main things they come for us to vet the joints. And there's the T-Scan EMG being used simultaneously. All right, I got a question for the audience. I want to wake everybody up here. How accurate is ink ribbon, articulating ribbon? How accurate? We didn't learn this in school, but how accurate is it? We all use it. I use it myself, but I don't trust it. And I'll explain by the end of the lecture, you'll get it. In the literature, how accurate do you think an articulating ribbon really is? Relative to force and time, like what hits when, which was what we're doing when we're chewing, right? Think that might matter? 12 to 38%, depending on the study. I want you to think how poor that is. It's analog and it's subjective. That's a pearl. Understand that your articulating paper is crap, basically. Excuse the language. Now, how accurate would you think the T-Scan is? The digital sensor, relative to force and time. The literature supporting it is down below. 95%. It's not perfect, but 95 trumps 12 to 32, correct? So I'll use articulating ribbon, but I won't ever make occlusal adjustments, even in my operative world or my normal crown and bridge stuff. I'll look at the ink marks, but I will trust the T-Scan. I don't trust the ink marks. I can tell you from using that thing for, going on close to 20 years now, there is no way. I can't practice without it. And no dentist should. Any dentist that refuses to bring digital occlusion into their office, they're, good luck with all those recalls and all those problems after crown preps and insertions and fillings, and they come back repeatedly. Now, nothing's perfect, okay, but this will help you reduce that greatly, make you way more efficient and have happier patients. Now, why do I say this 1/3 thing? Why is it 1/3 of the objective occlusal efficacy? Well, digital and objective, right? Very important. Because as I mentioned earlier, the TMJs are 2/3 of the human bite. So 1/3 is mandibular teeth hitting maxillary teeth. Another third is the right joint. Another third is the left joint. We need to understand that. It's like a three-legged stool. If the stool does not have, basically, if you're one shorter than the other, the whole thing wobbles. The whole system is out of whack. And by the end of the lecture, you guys will get this. We've got hard tissue and we've got soft tissue in the joints. Example, the cartilage itself. You can't see cartilage on MRI, on CT. You can only see it on MRI. An MRI is unbelievably important. When you understand, if you learn to live in the world of MR, it will change the way you practice. It will change the way you diagnose. It will change how you do a veneer or a full mouth reconstruction or a facial pain world, help you figure out what's wrong with people. It's absolutely amazing. And you combine that with a CT, it blows things away. Okay. The CT shows me basically the past and the present condition. I'm looking at hard tissue. The MRI shows me the present condition of the joints, and it also helps me predict the future. So the MRI is the crystal ball as to whether or not I can proceed with treatment, the splint, the full mouth reconstruction, whatever it is I'm doing. And it keeps me out of trouble, and the patient as well. It's the gold standard, the MRI is. And believe it or not, I as a GP order 1 to 2 a week and do it on the regular, do it very routinely, just like I sign a prescription for something sent off to the lab. Just as easy to sign a prescription for an MRI once you understand how to do this stuff. We teach this in the CNO curriculum, by the way. There's a course called CNO 3. If you're interested, and I hope you are, you can take that thing online. And it's done by myself, a TMJ surgeon, and a medical radiologist. It's an amazing course worth HEDCE. Pearl, very important to understand. Now we're going to get into the nitty-gritty about the 2/3 thing. I need to show this. Believe it or not, it is salient and has to do with hypersensitivity. JBO, joint-based occlusion. What am I talking about? Well, I alluded to Mark Piper earlier. Those of you that don't know him, he was at the end of the Dawson curriculum. He was one of Pete Dawson's best friends. They worked together. When Dawson couldn't figure it out, Piper's the guy that figured it out. This is me with Piper in one of his operating rooms. This is one of my patients, a 16-year-old open joint surgery that was unbelievably indicated. That's a whole nother story. I can tell you that over the years, I've sent over 100 people off for TMJ surgery, and I don't regret a single one. They're all better. Now, I'm not saying they're necessarily perfect, but they're unbelievably better than they were initially. And remember, excuse me, I see some unusual stuff when they come from all over the world. So now, relative to my Arkansas practice, I've been in Arkansas a little over 9 years now. I think I've sent about 5 people in 9 years off for joint surgery after running them through screening, the neural occlusion screening protocols. And this was one of them. His dad was a higher up at Walmart. They had not found what was wrong with him for several years. The kid was popping pain pills. He's about 16 at the time when I met him. Guess what? He had cold sensitivity, amongst other symptoms. Chronic pain. The cold thing was minor, of course. Chronic pain, tension, failing in school. Good kid, good student. Couldn't figure out what was wrong with him. Bottom line, joint surgery was part of what was wrong with him. All right, so when I first met Piper, it was when I was first writing the first edition of that Tscan Bible. And Piper had heard of me. And basically, he and I met in 2013. And he's the one that taught me over time about the MRI and the CT, about TMJ surgery, the indications and the contraindications, etc., and the various types. JBO, which is what we're talking about here, soft tissue discs, hard tissue bone, cervical, neck, sensory inputs, the sympathetics, the autonomics, and the relevance to dental medicine, growth and development, anterior open bites, all these crazy things that we all think we know all about. There's a lot more to it. And allodynias, which is the pain that's disproportionate to the inciting event. And he and I began collaborating. I was sending patients his way. We started lecturing together. I started throwing him on my YouTube channel. I would interview him, and basically, this is kind of a quick snapshot of what we did together over the years, patients we shared. This is me in his clinic, the Piper Clinic. He and I lecturing in Marquette, American Academy of Craniofacial Pain, Steve Olmos, myself, and Piper. Piper, it's been almost 2 years, he retired. And he's on a tractor in Tennessee, loving it. He's basically turned into a developer. He's enjoying life. He's done with, in our world. All right, so here's the JBO thing. Anomalous Medical is a software that Piper's son, and I think his name, Andrew, software engineer, created this for his dad. Dad gave him about $1 million to put this algorithm thing together. And this is just a very quick and basic look at the software. Is amazing. I highly recommend. It's a freeware nowadays. You guys should grab it. I use it constantly in hygiene, especially on new patients. I'll use it probably 3 to 5 times a day. Basically, sagittal view, sideways view, ear, external auditory meatus, C-spine, C1, 2, 3, condylar head, cartilage, 12 noon, 1 o'clock, 2, 3 o'clock, posterior band, anterior band. Blue means teeth are touching, white means they're not touching. This is perfect health, 1 o'clock disc. Sagittal view, on an MRI you can see this, on an MRI, properly exposed one. So I'm going to play the video now. Another thing to know is that there's ligaments holding the cartilage atop the condylar head. So if we're in perfect health in the joint, this is basically one unit. As you open and close, this moves down, open, back in the hole in the fossa to close, back and forth. The cartilage is basically a buffer between the condylar head and the temporal fossa, okay, the articular eminence, etc. So understand the anatomy of the cartilage. There's a differing thickness in the posterior band, the intermediate zone, and the anterior band. So let's start messing with displacing disc a little bit. In other words, trauma, accidents, sporting injuries, blows to the face. There's 12 o'clock. There's 11. There's 10. 9. And notice you're off the disc now. And notice how you've got all this going on in the posterior. By the way, if you do this bilaterally, let's say you have a car wreck and you pop both your discs forward. Guess what happens? You get an anterior open bite. Okay? I want that to sink in for a minute. So posteriors, too much contact. That is a stimulus that can cause problems. What kind of problems? We'll talk about in a moment. Excessive posterior excursive interferences can be very problematic. Okay, so I want you guys to understand that displaced soft tissue can alter the bite. Hence, this is 1/3 of the joint. There's another third, and the other third is on the other side of the head. Okay? 3-legged stool. Remember this. All right? So too much posterior contact, which you can measure digitally and objectively and have a record, can be very problematic. Pearl. So what the heck does JBO have to do with hypersensitive teeth, right? Well, excessive posterior excursive interferences can be problematic, as I mentioned. They can cause headaches that nobody can figure out, an allodynia. They can cause cold hypersensitivity that's confounding, no one can figure out, another allodynia. It can cause dystonia, spasm, trismus. Okay? We're going to get to that. We're going to show some videos at the end. Now, understand that based on what you just saw with that video from Anomalous, was the alteration in the occlusion that caused those posterior teeth to bang together too much, too long in time, was it orthopedic? Or was it iatrogenic? Do we have a displaced disc that's screwing with us? Or do we have, let's say, orthodontic work that we did, or our orthodontist did, or someone else did, or maybe a filling or a couple of crowns? I mean, maybe we've thrown the system out of whack. Okay, I can track these things with the digital metrics. The normal guys cannot. And I know there will be people in the audience that say that they can, they cannot. This is a pearl. This is very important to understand. So what does normal look like? We don't have time for this, okay? But basically I wanted to throw a quick slide in, hard tissue and soft tissue. Basically, the disc is about 2 millimeters thick. I mean, there's a differing, like I mentioned earlier, there's a difference between the posterior, intermediate, and anterior, but in general, the average is about 2 millimeters. That's an MRI in the coronal front to back view. And then CT-wise, example, ramus heights. That's huge. This is normal. I had a patient this morning. Her ramus height was 55 millimeters. On one side, she's 50 years old. Other side was 58. She had a growth defect. She had trauma. 65 to 75 is the normal ramus height. Something below that means they had a trauma, an accident, displaced the disc when they were a child, and they never grew fully. It's akin to breaking an arm, never having it reset, and the other arm grows to full genetic potential once you're an adult, but the one that you broke as a child does not. Okay, this is what normal looks like. There's so many things to look for, but this is just a quick intro. Understand that the hard tissue and the soft combined can alter your occlusion. I want you, one last example. I want you to think of the hinge of the door, the mandible. I want you to take a crowbar to that joint, and I want you to bend it a little bit. Do you think the door might hit the jamb, which would be the maxilla with the teeth connected, a little bit differently? So soft tissue displacement is akin to altering that hinge of the door. All right, I think I made the point. That 2,000 microns makes a massive difference in the bite. Again, I'll mention CNO3 if you guys want to learn about TMJ imaging. A very important course. All right, JVA, I mentioned this earlier. I do this on everybody. Little accelerometer. It's like a little headset that we place in front of their ears, right over the TMJ. It senses vibrations that would emanate from the joint if the cartilage was loose. And in this scan, for example, I can tell there's bone-on-bone action. Okay? So why would there be bone-on-bone? Well, you've already seen why in that anomalous rendering. So JVA, 20,000 plus. There's more. I guarantee you I've done more over the years. How many MRIs? About 500. And every single patient that I take MRIs on, I also have JVAs on. So guess what? I have a very good understanding of how accurate JVA is. JVA is extremely accurate, almost perfect, when the joints are not that deranged. And most of us would think that's most of the time they're wrong. It's the opposite. Most of the time they are deranged. I look at JVA 20 plus times a day for 15 years. Oh, longer than that now. Anyhow, my point, the more normal the joints are, the more accurate JVA is. The more deranged, more damaged the joints are, the less accurate it is. So when I see a really messed up scan like this, and they've got some chronic problems that I can't figure out, that would be an indication for an MRI. All right. So I need to mention reading bites. This is something else I do for everybody, like a new patient walks in. What's reading bites mean? Well, I combine the JVA with reading bites to ascertain whether or not I want to order an MRI. And I'm going into this for a moment. You'll understand why later. Have them go to IEP. Have them protrude their mandible. Midlines coincident, edge to edge. Look for posterior clearance bilaterally. This is good. This is normal. There's a thickness to the cartilage between the right TMJ and then we got left over here. If that cartilage is displaced, I want you to think about that thickness being gone and maybe these guys banging together on that one side, but the other still clears. IEP, everyone can do that in about 2 seconds. Just a real quick way of vetting someone's joints. Now, orthodontic movements will alter that, so it's not always accurate. But let's say you've got a virgin patient, virgin relative to orthodontic work, never had any, and you look at this, if they're banging together in those posteriors at IEP, there's something wrong. If they've had ortho, a lot of times the orthodontist will kind of screw that up in space, spatially. Another way we can look is at CEP. The IEP is a critical must. CEP you should do. Left CEP, a little bit of clearance in the working, a lot of clearance in the balancing, that's normal. It's suggestive that we have normal discs, or we have something, maybe the retrodiscals are taking it on, but, how I've been asked many times over the years, when do you take an MRI? I'm trying to show you. JVA looks bad and reading bites looks bad. This is what perfect looks like. Edge to edge, clearance bilaterally. Left CEP, a little bit of clearance working, a lot on the balancing. Right CEP, a little bit of working, a lot on the balancing. That is what great looks like. Okay? So check the TM joints by reading bites. Pearl, big time. What's abnormal look like? Let's talk about that real briefly. At IEP, they're banging together in posteriors, they're not even getting end to end. Well, maybe they had an anterior open bite. Well, maybe that anterior open bite was because of displaced discs, like we saw a few minutes ago in anomalous. Maybe, maybe not. Now they're making a move off to the left. They're trying to go edge to edge, but they really can't. I mean, they kind of hit that canine to that lateral, but notice there's no clearance on the working or the balancing. When they go to the right, I'm sorry, that should be a CEP. When they go to the right CEP, they're banging, working, and balancing. This is not normal. If I saw this on a patient and I saw a screwed up MRI and they were symptomatic, they were having a problem, 100% CT MRI time. If they don't want it, they can go somewhere else. And by the way, they pay me for diagnostics. When I run them through screening, I get paid for that. They pay me about $4,500 just to diagnose them. It takes me a morning. So I want you to understand that you can run a business and do this stuff. Anyhow, I'm getting too deep into the TM world. We got to speed up. So real quickly, IEP looks good. This IEP doesn't look so good, does it? On their left side, at IEP, midline coincident, they're banging back here, they're clear here. Guess what? This left TM joint could have a disc displacement, especially if they had no ortho treatment. Or it could be they had a bunch of dental work, but I mean, there's some here. I don't remember there being any there. You get the drift. A a real quick look at how to do this in the real world on reading bites.
Now come edge to edge. Perfect. Separation on both sides. You see the left and the right. Now bite back home. Now go to the right excursion. Don't move. The working side has less clearance than the balancing side does. That's healthy. Bite home. Now cannon to cannon left excursion. This is now the working side. It has less clearance than this balancing side, which is healthy as well. She likely has good disc position, condition, and lack of herniation. Bite back home. Great.
That's important to understand. How long did that take me? About a minute. JVA, my assistants do that. It takes them about a minute. So 2 minutes is part of what makes us different. When patients come in, they see that. They've never seen that before. All right, let's get back to cold. That's why we're here. Hypersensitivity theories. Why do I have 2 sensitivity all of a sudden? I mean, quick little moniker here. We've got the hydrodynamic, Bransford and Anstrom, the 60s, right? Fluid flow, dentinal fluid flow. We have a odontoblasts transducer, RAP in the 70s. They never could quite prove the odontoblasts. It's not a good working theory. Bransstrom's is better. And then some guy, yours truly, in 2014, that's when the first edition of the Tscan Bible was written. That were published. I wrote it in 13. And then there's STH, Piper and Llanos, myself and Mark Piper. That's the sympathetic thing. Traditional definition of DH or CDH, they're pretty much related. And they're intertwined. They call these things all these different names for the same stuff, okay? But basically understand that what we've learned about fluid flow and all that is relevant. Most of the time when you run into cold sensitivity, that is the problem. I'd say about 70%. And most of the 70% is like with the CDH, the cervical dentinal. So dentin hypersensitivity is defined as a short, sharp pain arising from exposed dentin in response to stimuli that are typically thermal, evaporative, tactile, osmotic, or chemical, and which cannot be ascribed to any other form of dental defect or pathology. We mentioned this earlier, process of exclusion. Okay? There's an SEM of a cross-section of a tooth showing dentinal tubules. The red arrow is pointing to a red blood cell, which typically they're about 6 to 8 microns. So that'll give you a quick reference to understand tubules. They're 2-3 millimeter or microns wide. And by the way, they get thicker towards the pulp, thinner to the periphery. So, the fluid flow, the hydrodynamic thing, we're talking fifth cranial nerve, trigeminal, right? Here's an update back around the 90s, mid-90s, a guy named Pashley, Dr. Pashley, a researcher. I think he was out of Alabama. He was big into hypersensitivity, and basically they made a distinction, for those that have never heard this yet. DH, basically we're dealing with occlusal and incisal dull pain. I want you to think C-fiber, unmyelinated, slow, dull pain. CDH, cervical, Pashley, and the rest of them, they made a distinction. This is more sharp pain. This is more a delta. This is fast pain, myelinated pain, okay? We all run into this, especially that 25 to 35-year-old. So I'm not going to get too deep into this, but I want you guys to remember we're displacing fluid in the tubules, hot air, whatever, cold, hitting things. And there's a quick, really good diagram of an illustration of some attachment loss, recession, exposed dentinal tubules. And notice as you get towards the odontoblast, towards the pulp, things get wider and softer. Those of us that excavate caries all day long, we know that the deeper you get, the softer it gets, the more you pucker up, you've almost got an exposure there, right? And we're hoping not to have one. At least I am. And there's an SEM of occluded dentinal tubules on the top and tubules that are wide open on the bottom. The goal when we're trying to desensitize someone, or if this happens naturally, which it usually does, okay, this will usually happen. Not everyone with recession, as we all know, has hypersensitive teeth. But when this is wide open, oftentimes they do. The goal is to clog that up. And these are the various things, I'm not going to get too deep into this, that dental world basically talks about in textbooks and CE courses and HEMAs and glutaraldehydes and dentin bonding agents, etc., etc. You want to clog that stuff up. Well, most of it doesn't work. They come back a couple of months later, they got problems. You told them to go home and use the Sensodyne, etc. It doesn't work. Not predictably and efficaciously. I don't have any of those in my practice. We don't use them. Of course we don't use fluoride. I'm a holistic guy, by the way. All right, so what is FDH? Let's talk about that for a quick minute. So, no recession, no exposed dentin. Process of exclusion, you've already checked the boxes. There's nothing else going on. What could be wrong with them? Why? And we've all seen it. Occlusion. There's something not right with the occlusion. Could be someone that's just out of a liner therapy or ortho. Well, basically, excuse me, FDH, we're dealing with mechanical flexure in the dynamic and excursive movements. Okay, I mentioned that earlier. And we can track that with Tscan. All right, cranial nerve 5, sympathetics, what are we dealing with? We're dealing with something called crosstalk between those two systems. So it's deep stuff, and no one understands it all, myself included. But I can tell you that when we're talking about hypersensitive teeth from the occlusion, it's not just trigeminal. It's also the autonomics. All right, so I want you to think sympathetics, and most of us don't know this, or maybe forgot this. We may have seen this in school. This is in most of the textbooks. A smaller population of pulpal nerves are autonomic sympathetic fibers emanating from the superior cervical ganglion and associated with pulpal vasoconstriction. I want you to remember that and burn that in your mind for the rest of your career. This is one of the biggest pearls in the practice. Sympathetic nerve fibers emanating from the superior cervical ganglion, the neck, 10% in the pulp, in the vital pulp. Think about that. What might that have to do with our world? And remember, we're giving blocks all the time, but they're trigeminal only. But you've got 10% of these things coming from the neck. So just remember that thought. Big time pearl. 10%. I'm going to underline that. 10% pearl. Now, most of us, at least I graduated dental school from San Antonio in '93. I learned all about C fibers, the unmyelinated slow. I learned all about A delta, the myelinated fast. But you know what? The guys in the med school next door to us, they learned about A beta, but I didn't learn about A beta. The fly or the mosquito that lands on the back of your head or your neck and you swat at it real quick, they triggered your A beta receptors, dermal receptors. They're basically proprioceptive receptors. So they didn't even know A beta was in the pulp. Histologically, they didn't find it till I don't remember exactly the year, but 2000 something. So why would you have proprioceptive fibers inside the hard tissue shell of a tooth? And those of you who haven't heard of a compartment syndrome, basically there's no room for volumetric expansion. So if you get swelling inside a dental pulp, you're in trouble because there's no room for expansion, right? You get swelling, you get edema, swelling. You can occlude blood vessels and restrict blood flow, get hypoxia, ischemia, necrosis. So when we cut crown preps, like a real simple one, wasn't deep, wasn't a big deal, or a deeper filling, or a medium filling, or maybe a shallow filling, and they come back 6 months later, 3 months later, whatever, needing a root canal or an extraction. Why did that tooth die? Oh, it was a cracked root or a cracked crown. No, not necessarily. You ramped up sympathetic tone. Understand that I've been looking for years. There is nothing in the literature that talks about parasympathetic fibers in the dental pulp. The rest and digest, which vasodilate. There are sympathetic fibers in the dental pulp, which vasoconstrict. Vasoconstrict, less blood flow. Vasodilate, more blood flow. Understand that in most parts of the body, we have parasympathetic to countersympathetic fibers and vice versa. The dental pulp lacks parasympathetic. So the A beta thing, basically, we have touch fibers inside the hard shell of the tooth. Why might that be? So back in the day, in 2013-ish, I'm streaming through literature, spent a year in it, reading article after textbook after chapter this, etc., trying to figure out why in the heck what I was seeing with the cold based on the occlusion, why was it going away when I altered that? Basically, I'm decreasing the amount of time that posterior teeth engaged with one another, top to bottom, in an excursive movement. Well, you need to understand this concept about the A beta. This is the working hypothesis here. Touch proprioception, right? Big time pearl, A beta. So I ran into this other thing. There's a researcher down in Australia. This is a 2008 paper. Linsawanant. Basically, hear this. Application of thermal stimuli to the labial enamel surface resulted in a rapid development of strain at the pulpal dentin surface before any temperature change was detected at the DEJ. The strain pattern was biphasic. Heat produced an initial contraction of the pulpal surface followed by an expansion, and the reverse pattern was found with cold stimulation. They used finite element analysis, okay? Basically, they were able to see these thermal changes on a microscopic level. So, underlined in red there, mechanically induced dentin deformation may trigger nerve impulses directly, or may exert mechanically induced dentinal fluid flow that triggers nerve activity. It's almost like a flexure thing. So basically, before the fluids or the thermal change had a chance to get from the outside world into the pulp, the dentin already snapped. It already knew it. The pulp knew it because the dentin bent. Strain deformation. Basically, I call this strain deformation. Okay? So thermal changes will actually kind of snap a tooth. And all of a sudden, the inside, the A beta, feels it. To this day, I can't find a better explanation unless I start thinking in the autonomic sympathetic world. I think it's a combination of the two. Big time pearl. This is an alternative to the hydrodynamic theory of Brandstrom. Okay, so A beta responds to mechanical stimuli, and it's extremely fast, by the way, and it's omnidirectional, by the way. In other words, most periodontal nerve fibers that talk to brain, proprioceptive stuff, etc., we're talking PDL now, they're unidirectional. Omnidirectional A beta is in the pulp, and there's just a very few of them, very small percentage. It's almost like a 3D hologram. The data is like amazingly important that goes to the nervous system. All right. So let's talk about diagnosing and treating the FDH endotype. But first, I'm going to show you a quick look at what Tscan usage looks like. That was a left movement.
Clutch.
Now here's a right movement.
Touching him to him, teeth together as you go.
Okay.
That's my lovely wife.
Bite on hard, 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 hard. Right. And open. Great.
Right and left excursive movements. How long did that take me? I have a permanent record. And we don't have time to go too deep into this, and I've already kind of showed you guys the force and time thing. You have a two-dimensional and a three-dimensional representation. As I play the movie, this little kite is the average of all those relative force percentages. At that moment in time, now she's starting to move, or this patient is off to the left, and look at all these posterior interferences in the back as it's struggling to make its, let's say you're in the center of the U.S., you're in Kansas City trying to fly to San Francisco, but you were being hung up by these other things. That's an analogy I use for patients a lot. Trying to make a right movement, all these posterior interferences, that's relevant. And every time I move this cursor, 3,000 of a second, you cannot see this with ink ribbon. And much of the ink ribbon, the data that we interpret in our minds is bogus. I can tell you because I look at it all day long, comparing it to the real thing here. A quick look at T-Scan. We don't have time for this, but that's T-Scan and EMG combined. Come to a CNO1 course if you want to learn more. Yeah, that's where we go really deep into this world. By the way, the CNO1 course, you can do that online or live. I think we've got a course next July. Mid-course corrections, that's important. Oh, hang on, I got to back up. I'm quantifying occlusion here, right? Putting numbers to things. So how do I quantify hypersensitive teeth due to the occlusion? Well, there it is. In the research, if it takes me less than 0.41 seconds to make an excursive movement, in other words, 0.41 seconds to get off of all of my posteriors when I'm making a right or a left excursive movement, that's the gold, if I'm looking for a number. Okay? If it takes me longer than that, 0.6, 0.7, 0.8, not everyone's going to be sensitive, but oftentimes they are. If it's less than that, almost no one's going to be sensitive. This is kind of a statistical average. Okay? Now, I don't have to just look at timing. I can also, and in my opinion, this is more effective, I look for geometrical changes. Look at this real quick. There's the kite, that center of course icon. Now watch it. They're clenching, they're getting ready to move to the right. That little kink, that's called a mid-course correction. The kink happened because something interacted on the right posterior. Make a couple of swipes at that, maybe that crown or that filling that's causing that little inefficient movement, and watch their cold sensitivity go away. Again, if you want to learn this, CNO1, hands-on. All right, so how do we treat FDH? We confirm stable and adaptive joints. JVA and reading a bite. Everyone here can do that. I call JVA the poor man's MRI. If I need an image, I mean, that's pretty rare in my normal practice, but every now and then I do it. But look, in general, I probably order 1 to 2 MRIs on my normal patient pool a month, max. And I see at least 20 people a day. Between hygiene and my own side. So, the imaging, for most people, it's good. It's extremely important. And if you go there, I applaud you, and you really should. But, learn how to read a bite minimally. Spend a little bit of money on JVA if you want to get deeper into this world. And then eventually learn how to shoot the MRI. So we decrease the exclusion time to less than 0.41 seconds via precise occlusal adjustments based on the Tscan data, not on the ink ribbon. Or we straighten the mid-course. Okay, we already went through that in the last slide. That's how you treat FDH. That's also how you diagnose it. All right, so I have to spend a couple moments really quickly on curing the common. As I mentioned earlier, probably 70% of the cold sensitivity that I run into in my practice, and I assume it's pretty universal, is going to be CDH or DH. Usually CDH, usually a sharp pain, right? And there's our famous SEM with the clogged and open tubules. So what's the goal with lasers? When I'm using lasers, I want to recrystallize dentin. I want to occlude the tubules. I want to shut them off. I want to coagulate proteins in the dentinal tubules. I have them swish ice water. I hit them with the ND YAG first, and then the ER YAG. There are the settings. If you're a Lightwalker owner, they're built into your unit. Then I hit it with 50 gamma ozone. By the way, every time I'm using the ND YAG or the erbium or the ozone, just remember the magic number of about 10 seconds per buccal surface. It's usually the buccal you're treating. They will almost always go away. So it's not that expensive, doesn't take that long. I think we charge about $140 for a quadrant. And it's a way to check a box. Process of exclusion, you figured out, everything else is clear, or they've got a virgin set of teeth. Maybe you got a tiny bit of recession. Maybe there's a reason for open dentinal tubules. Then you hit them with the laser or the ozone. It's very predictable and it's lasting. So, as I mentioned earlier, 70%. The FDH, if that doesn't work for them, process of exclusion. It could be FDH. Now you're going to work them up for bite, if that's what you want to do. About 20% of the time, that's the cause of their cold sensitivity. It's confounding. Now we're talking about confounding stuff, right? Now, if you really can't figure it out, and maybe you've adjusted their bite, and you know the joints are in decent shape, could be SDH, coming from the neck. About 1 in 10 cases, it's coming from the neck. In my experience, in my own hands. So, treating the DH or the CDH, ND YAG, erbium, ozone. I do not use fluoride. I doubt anyone in this audience would even go there. Now, what's SDH? Let's talk about that briefly. I'm not going to go through the entire autonomics. But basically, remember sympathetic, fight or flight, parasympathetic, rest and digest. The one critical thing I do want you to remember is that when we're talking sympathetic, we're talking vasoconstriction. We mentioned that earlier. That's important to remember. Vasoconstriction, down here, VC. Parasympathetic vasodilatation, increasing blood flow. All right, so quickly, some anatomy. SCM, superficial to that, I have a nerve right here, this yellow thing, the great auricular nerve. Notice one arm of it goes towards the angle of the mandible. Another goes to the auricle or the ear. Neck injection. What am I targeting? They call this Erb's point. And that yellow thing is the great auricular nerve. And it's superficial to the SCM, sternocleidomastoid. So sympathetic, thoracolumbar. I don't want to get too deep here. Basically, we have first order neurons coming out of the hypothalamus. They run down the spine. They come out in the thoracic region to the lumbar region. I believe it's, T1 through L2. Then it runs out laterally to the sympathetic chain. Then you've got a synapse there. And then they call it second order neuron. And then in our case, those neurons that move north towards the head, they'll hit 3 different ganglion. They'll hit the inferior, the middle, and then the superior cervical ganglion. And cervical plexus is in this region as well. That's part of the superior cervical ganglion. And this is one of the branches it's the largest sensory branch from cervical plexus. It's a third order neuron. Now, what's important to remember is that we have myelinated nerves, first order, myelinated nerves, second order, unmyelinated nerves, third order, and myelinated nerves follow. They're like hitchhikers following stronger things like big sensory nerves, arteries, vessels, things like that. So that's going to be a pearl. We're going to talk more about that in a few moments. But I wanted you all to have a quick introduction to the GAN block. And remember, you hit this, a lot of times their swish goes down to almost nothing. Now, this is a temporary thing. This is not a cure. And there's more to learn. We'll talk about that at the end of the video. We're getting close to the meat and potatoes of GAN, and we're getting close to done here. So the great auricular nerve is the largest sensory branch of cervical plexus that feeds the lateral face. So cervical sensory nerve coming out of ventral C2, C3, ventral front side of C2, C3, that is the great auricular nerve. And remember, sympathetic, unmyelinated fibers hitchhike along the GAN. Think of the GAN like an interstate, and think of the sympathetic fiber like a hitchhiker, and he's using the interstate. And it's a way for sympathetics to make its way into lateral face, and guess what? The teeth, the muscles, the joint. Big time pearl. Quick videos. MAGD, Measured Anterior Guidance Development, Computer-Directed Occlusal Adjustment Procedures after objective confirmation of stable orthopedic joints.
That's occlusion.
I just don't understand how, without me interacting, how you can add or take away and affect tooth sensitivity. I just don't understand.
MAGD biomechanically and physiologically adapts the appropriate patient's static and dynamic occlusion to the status of their objectively confirmed, relatively stable and adaptive joints in a measured and objective manner.
To the background anatomy of this nerve, how it originates from the cervical spine, and how you get sympathetic input into this particular branch. And Nick is going to follow me. He has also integrated a lot of these concepts that I'll teach you into his general dental practice.
Noticing that their cold sensitivity is going away. The boards from the handpiece are blowing water on their teeth. And by the end of the procedure, they're starting to lose cold sensitivity. I'm actually starting to staticize this. I'm going to publish that.
She had to have the greater auricular nerve blocks in order to do the dental work. So first order neuron is all central nervous system. Second order neuron is from the spine into the sympathetic trunk. And then third order neurons are from the sympathetic trunk into the periphery.
I start pulling out ice water on every patient. Periodic exam, comp exam, toothache, you name it. Before we did anything, it was,
I'd say 9 or a 10.
Everywhere?
Everywhere, yeah. I mean, I just put it in and I almost was faking it just to get it down.
Yeah, it's nuts.
Yeah.
Okay, so. Without the EMG, I can't really know. Without the Tscan, I can't really know. I use them both. It's a tooth allodynia.
Okay, we already talked about this. First, second, and third order neurons. The GAN is a third order neuron. So when we're giving that injection in the neck, we're blocking third order neurons. And remember that 10% sympathetic in the pulp. Another quick video.
And allodynia is a pain response that normally wouldn't be there to the stimulus. A good example of that is cold exposure, okay? And you guys remember Nick Pianios lectured to the study groups when we were together last fall.
It's basically computer-guided bite adjustment, okay? So as I'm proceeding through that, I started noticing that the cold sensitivity went away by the end of the appointment. Even though I hit water and burr on the same area, the same tooth.
Like him or not, what he's come upon is sensitivity in teeth, and the adjustments that he's doing are actually reacting some to the edema. He's taking some of the edema down, and the cold sensitivity stops immediately. As a pearl, if you have a pulp that is sensitive to cold, okay, if it's the sympathetic endotype that's causing the cold sensitivity, when you block the greater auricular nerve or transverse cervical a little bit lower, that sensitivity goes away like that, okay? The nerve block stops the cold sensitivity. You can have them do a swish test. Following the nerve block, pain is gone, okay? Now, if you're pre-necrotic, then the treatment is on the sympathetic side. Does that make sense? So it's on the sympathetic side, and you take care of whatever's causing those sympathetic nerves to be hyperreactive, okay?
I thought this crowd might enjoy that because basically we're talking about maybe possibly staving off endo, right? All right, so this is very important. The sympathetics trigger what? An inflammatory response, okay? Vasoconstriction, inflammatory response. So we have subsequent leakage of the blood vessels within the pulp. Remember, it's a compartment. Remember the compartment syndrome complex or concept. Basically, there's no room for expansion. So this inflammation causes leakage of blood vessels in the arterioles within the pulp. This creates edema. It starts kind of clogging up in there. No room for expansion. Starts constricting the blood flow to anything distal to that, and things can become hypoxic, ischemic, and then eventually necrotic. Now, this also happens in muscles, and you can have claudication. And we're going to go there in a minute, briefly, because I want to show this audience other things that the sympathetics have to do with our everyday practice that you never would have seen before. And remember the endo implications for what Piper was just talking about. If it's pre-necrotic, there's a decent chance you've got a problem that's sympathetic. Quick side note, when I do lower crown preps, or say I want to take out a wisdom tooth, and let's say I know the patient really well, so they're not going to wig out when I come at them at the neck. And of course I give them informed consent and explain why. I will routinely give a great auricular nerve block. I do that. I have very, very few, never say never. Every now and then it still happens to me too, but very few post-op endo problems. Now this is pertaining to lower molars. Okay? The great auricular nerve, we're talking lower molars primarily. I'm not saying it won't affect the rest of this, the maxillary and etc., but it's primarily lower molars, okay? Where it will kind of counter the vasoconstriction. That's the point of the block. So what are the implications? Well, there's other implications here. I mentioned claudication, trismus. You ever have someone lock open, and let's say it wasn't orthopedic, let's say it was muscular? Let's say you had a clean JVA on this chick. She's never had a problem before. And you're in the middle of working on her. JVA was clean, reading the bites was clean. Don't have a scan on her because she's a young girl and asymptomatic, and you're in the middle of doing something and you got to get back in there to finish, and she's basically not able to open all the way. Headaches. Remember we talked about too much contact in time, the excursive movements? Well, also headaches can be autonomic sympathetic too. You're starting to see the kind of crossover between FDH and SDH. So a couple of quick videos. We're almost done here. But I wanted the Academy to see this. 5 seconds. What do you got? Ice water. 10's the worst pain ever.
About 7, 8.
GN block.
All right. No poke.
Using Marcaine. That's an ultra short needle.
Was something changing all right?
I don't know, I still feel some burning over here, but not much over here.
Think about that.
Burning behind the eye.
Burning sensation behind her eyes.
So the burning behind the eyes over here just went away,
It seems like it.
but you still have it over here.
Mm-hmm.
The sympathetic thing, remember the hitchhiking nerves?
Mm-hmm.
That can cause the burning sensation.
Okay.
Swish the ice water again. Because we just did it a minute ago. Tell me if it's different.
The bottom I didn't feel much earlier, now I don't feel any. Up here, I felt some, but now I only feel it from here over.
So we blocked her right great auricular. One of her chief complaints, she was an orofacial pain patient. She was not a normal local patient. One of her chief complaints was a burning sensation behind her eyes. So I blocked the GAN, and on that right side, the burning sensation went away. It floored her. She couldn't believe it. And her cold sensitivity went down. In her case, not super substantially, but it did change. And then after that, I blocked her left side. Guess whose burning sensation behind the eye went away there? By the way, quick pearl. You ever had a patient where cold causes burning pain? I want you to think autonomic sympathetics, and there's a concept or something known, a malady known as RSD, reflex sympathetic dystrophy, or complex regional pain syndrome. That's the new name for it, type 1. RSD or CRPS, CRPS type 1. Okay, burning pain is pathognomonic. Generally, that's a CRPS problem. Just like hypersensitivity, the CRPS diagnosis needs to be done by a neurologist. Most neurologists claim it never happens in the head and neck. They're dead wrong. Piper and I worked together for many, many years. About every third patient that went to the Piper clinic, at the bottom of what I call the funnel of hell, people that couldn't find help anywhere, about every third patient had CRPS. And most physicians say it can't happen in the head and neck, but it does. By the way, there's a book out there. There's a guy named Waldman. Go on to Amazon or Barnes & Noble. Type in Atlas of Common Pain Syndromes. He also has a sister book, Atlas of Uncommon Pain Syndromes. Waldman, out of UMKC. He's an anesthesiologist, pain doctor, and he's also an attorney. He's got a JD as well. The guy's written many, many books on pain. And CRPS is listed in the Atlas of Common Pain Diseases. But my point here, that was a side note. I wanted you all to see that burning pain thing, not just the cold. Now let's talk to this nurse practitioner.
A few months ago, I came in and was having severe left-sided jaw pain. I couldn't even, like when I would open my jaw, it felt like someone was stabbing me.
What do you do for a living?
I'm a nurse practitioner.
Yeah, so what did you think? What did you think was wrong?
I thought it was my TMJ, but I have like popping on this side, and I was like, I don't understand why this would be popping. I put a little anesthetic in my neck, and it numbed it up, and the pain like went away immediately, and then it was gone for like 24 hours, and then exactly the 24-hour mark, I started to get feeling back in my jaw.
And then it was kind of normal?
Yeah, I mean, it was probably like 5% of what it was. I could actually open my jaw without having tears in my eyes.
Yeah.
And then, gradually over the next few days, it went away completely.
So ever since, no issues?
No, I haven't had any issues.
That's awesome.
Yeah.
Sympathetics, autonomics.
Yeah, it's amazing.
It's not just trigeminal. Yeah.
Right,
it's cool
it's amazing.
Thank you very much.
Thank you.
So, quick pearl. This was filmed about 2 months after we helped her. I mentioned earlier that a lot of times you'll get the GAN block, and the cold thing, it's not a lasting thing. It'll only last for the duration of the block, but it's diagnostic. It helps you understand if you have ramped up sympathetic tone in that patient. When it comes to things like trismus, it tends to be lasting. I can't tell you the number of patients, probably once every month or two, I'll run into something like this, neck block, and it's usually, that's their fix. For whatever reason, they had ramped up sympathetic tone that day. Now, someone like her, I gave her the option of working up her joints. Let's do the screening. But she's not symptomatic. She doesn't want to spend the money, and I don't blame her. So this is a pearl. Here's another one. I'm going to run through this one quickly. Basically, dry socket. This is the only time in my career since I've been doing PRF, which, I'm trying to think, 6-7 years, where I had a dry socket post-op. Notice I'm using the neodymium to vasodilate.
Okay, lift your neck again.
The R30, right? And then I hit her with the GAN block, and she had some trismus as she walked in.
I think these things should help you. Let me see you open.
A few seconds later, she can start opening bigger than she could before. It started to take down the trismus. Remember we mentioned about sympathetics, inflammation, blood vessels kind of blowing out, edema, hypoxia, claudication. You're eliminating this hypoxic problem, and you're opening up the blood vessels when you do the combination of the neodymium and the GAN. You're vasodilating between the laser and blocking the sympathetic hitchhiking guys that are hanging out on the GAN. This is a very common, very practical thing. This patient couldn't get her numb. We confirmed blocks, the lower block. We confirmed midline zonked to the midline. And then one side of her tongue, this is the left side, zonked completely. Yet she still felt things. We've all run into this, right? Watch this.
Guess what? We figured out why you won't go numb. Them sympathetic. Feeling that?
Looks familiar? Open for me. Close. You good? Hang tight. Little poke. Not too bad, is it? Stay back and relax. Perfect. Now stop again at the stroke. If you're still feeling, I'm going to do one last time. That woman has never been fully numb on her lower.
Yep.
As her treatment plan, she's a new patient. Is that better? Her entire life, every time a dentist has worked on her lower teeth, they can never get her completely numb until that day.
Easy?
10% dental pulse, sympathetic nerve
fiber. Well, we figured out why you won't go numb. Them sympathetic.
You starting to understand why this guy was sensitive? Our Hollywood patient? He was switching a 4 out of 10. After GAN block, he was switching a 1 out of 10. What'd that tell me? He had ramped up sympathetic tone. Might it have been so ramped up that it was considered CRIPS or RSD? Or was it just part of his problem? It was part of his problem. He had C-spine problems. His discs weren't that bad. But this chronic pain problem, I don't want to get too deep into this. Bottom line, this gives you some insight into things that you didn't know about before. If any of you in the audience want to learn about this, like in depth, and want hands-on, come to CN01. We do it about once a year. We're doing it in July in Northwest Arkansas. It's very easy to get to. Walmart headquarters. Everything that was touched on in this video and more is discussed. I'm almost done here. I want to give you guys another pearl. Let's say you're afraid to do a GAN. You shouldn't be, by the way. It's been in the literature now 3 times between the 2nd edition of the Tscan Bible, the 3rd edition, and the GAN paper. But let's say you're sheepish and don't want to stick someone extraorally. Back in 2015, there was a paper written out of Temple University. And basically they described a new technique of doing intraoral sympathetic block called the intraoral cervical plexus anesthetic technique, the ICPAT. You basically take a long needle, no epi, shouldn't use epi, and basically aim at 45 degrees, as you see in the illustration here, towards the angle of the mandible. It won't work as well as the GAN, but I do use this routinely to augment when I give a lower block, especially on a patient that comes in saying they never get numb completely. About half the time this will work, and probably another 40% plus when this doesn't work, the GAN will. And then there's about, I don't know, a 5 to 10% chance that even if you give a GAN, they don't go completely numb. Then you pull out an X-tip. At least that's what I do. It's rare, ultra rare. I'm telling you, this sympathetic thing is usually the key. All right, don't be afraid. Like I mentioned a few moments ago, we've got the GAN paper out there now. I've been working for years on this to finally get it out as precedents. And then we've got the 2nd edition of the Tscan Bible and the 3rd edition, all talking about GAN and how we can use it in general practice. So
we did your bite stuff, and the cold sensitivity was mostly gone, right?
Yes.
Except you still have it in one area.
Just one main area, yes.
Can you point to that? The top of that canine on your bottom left is still
example of
sensitive, right?
DH. Yes. Remember,
All right, let's try the laser in the ozone. It shouldn't hurt. It might feel a little bit.
So we did our FDH thing, and her cold went almost completely away, except one area was still confoundingly sensitive. So we hit her with neodymium and erbium and ozone.
Smell a little bit.
Guess what happened?
What's the cold doing now?
Maybe a 1, if anything.
So it's virtually gone, right?
Mm-hmm.
So we knocked out the cold through the bite. We had one residual area, and we hit it with the lasers and the ozone. And now you went from a 5 overall to overall now, would you say?
I would say 0 to a 1.
0 to 1 out of 10.
If I counted that 1, yeah, 0 to a 1.
Nice. Pretty cool, huh?
Yep.
All right. Another Christmas example. We're just
Today
about
you showed
done.
up. Why'd you come in today?
I came in because I was experiencing pain on my right side when I opened my mouth wider than about here. So yawning, chewing.
All of it.
Talking, yeah, everything.
You got
was
maybe 2 finger widths in?
Yes.
Maybe.
Yeah, it was very limited, and it was discomfort that...
It was bad.
Yeah, and it would stick around for a while after.
So what'd you do? Or what did we do?
So we did a anesthetic shot in the neck, and that was less than 5 minutes ago, and now I can...
Wow.
Yeah. That's called the great auricular nerve block.
Okay.
Yeah, so basically the sympathetic stuff I was talking about, we blocked some of that flow. So let me see you move your jaw left and right now. Easy?
Easy. Yeah, easy.
Cool.
Yeah, yeah.
So what do you think?
That it's fast acting and it's effective.
That's pretty cool.
Yeah, I'm a believer.
All right, thank you.
All right, we're almost done.
Tell us what the problem was.
Hurt to swallow. Open my mouth and close it. Hurt.
So we just injected your neck on that nerve, that great auricular nerve, right?
Yes.
What changed?
Just within minutes, it didn't hurt to swallow, and it's already starting to feel better here.
Isn't that crazy?
Yes, it's unbelievable.
Yeah. All right, well, thank you very much. Let's see you swallow. Because it was hurting before you walked in, right?
Dysphagia. Gone. Sympathetic nerve block.
No problem? She wishes this was tequila.
Not even here. What'd he say?
You wish it was tequila.
Or a screwdriver.
Hell yeah.
All right. Our final video. saw you in 2017.
Yeah.
Right?
This example of your facial pain patient.
I was
Seemed to
having
be
migraines every other
years
day.
later.
And I went to different doctors and stuff, couldn't figure it out. And so I've seen your YouTube video and seen the TMJ thing. I had a bunch of, first of all, okay, back up. I had amalgam fillings in my mouth.
Yeah.
I went to a dentist and he removed them all. And he put in other fillings and my bite felt off.
Yeah.
And then I started getting the migraines and I went back to him and they had switched ownership a few times and nobody knew how to do it. And I searched and I couldn't find anybody to help fix me.
Yeah.
And I seen one of your YouTube videos and I told my wife I'm going to Arkansas. So I came here and you looked at me, readjusted my bite, built up my
your canines.
The canines. And I was here for 4 days. I left. Not another migraine ever.
To be fair, even back then we were in the screening protocol though before we even took on the bite, right?
Yeah.
Yeah. So that was why you were here for 4 days.
Yeah.
It's not like we spent 4 days adjusting your bite.
No.
Yeah. Yeah. Okay. So then you went home. Everything was good. You thumbs up, right? And then
I went back and I felt better. Every day I felt better. And after like a week or so, I was back to normal.
Great. So now here we are, fast forward, 7 years later or something like that?
Yeah.
Now you're back again. Why are you back this time?
Well, because I got a couple crowns from somebody that didn't know how to put them in.
Yeah.
And it screwed my bite up again, and I was having pain, and I got my TMJ back.
Yeah.
And so then I knew who to go to.
Well, okay, and so we ran you through screening again.
Yeah.
A day or two ago. Vetted your joints. Your joints are a little bit tore up, but they're adapted. They're kind of stable. So MRI, CT, all the EMG stuff, all that data gathering, the mastication analysis, everything digital. Then we decided we adjusted your bite yesterday. What's it feel like today?
It feels good. I mean, I don't have any TMJ or anything, but I had some other issues going on, but it feels normal.
So it's better now than when you walked in? Yeah. 0 to 10 on the ice water.
Yeah, that's still,
We got.
I think it's like a 2 or 3.
Wow. Because
it was that way yesterday too, and it's way better than it was.
So when you walked in, if I remember right, it was like an 8 or a 9, right?
Yeah, one side was like 8 and the other was 5.
Yeah.
And now they're both down.
And then we neck blocked you, and what was it then?
It wasn't a huge difference. Maybe it was a little bit of difference.
Yeah.
It was
5-6, if I remember right.
Yeah,
right?
5. Yeah, I think.
Yeah. And then now, that's substantial. Mm-hmm. And this one's lasting. The neck block didn't last.
Yeah, right.
Yeah, it's pretty cool.
All right. Close to the end. You're all welcome to join the Center for Neural Occlusion. It's a private forum for doctors only on Facebook. There's about 400 of us sitting there learning from each other. A lot of this sympathetic stuff, occlusion stuff. The CNO board, which is a teaching network. A bunch of radiologists, orthodontists, TMJ guys, normal GPs, orthodontists. Bunch of courses on CNO. Come if you can. If you love the Lightwalker and want to learn from Val Cantor and Mark Colonna, I think Mark's the guy that discovered PIPS about 20 years ago. He and I teach together. Val Cantor, I think you holistic guys know who she is. We 3 are going to be talking next July at CNO. Live course, hands-on. And CNO 3 I've talked about numerous times. Come. Actually, that one we're not doing live anymore. I've just filmed that one time, and it's there for posterity. It's an evergreen. That thing will never change. You guys go look at it if you want to learn. And the last thing is CNO 5. Anyone heard of Rick Myron, the PRF guru? How about Judson Wall or Terry Alford, laser guru? And Hud Judson's like ultimate, his holistic dental associate or courses. They're great. Love the man. He's part of CNO. We do online courses. We did 3 in a row. There's online options there. AGD credit. It's awesome stuff. And we're talking about PRF lasers, ozone, zirconia implants, and implants. Look, appreciate your time. Hope I wasn't too redundant. I hope I was able to get things across clearly. And I would like to thank everyone for having me. And I'm glad to have had to redo this because I was able to spend more time and get more out there. I hope to see the IAOMT
stage again sometime soon. Thank you.